Uh, ah,
Yes, we can see it just fine. Thank you.
cool. All right, so oops, 1 second here. All right, so a couple things. One, shout out to Derek Zielinski for wearing buffalo plaid, very nice. And as per tradition, I usually am wearing buffalo plaid and floral for presentations. Plus, I like to get sick at least one echo presentation, so I'm a little under the weather. So if there starts to be nasal discharge running down my face or anything, don't judge me too harshly, okay? I'm running low on my Alka-Seltzer from earlier. So anyways, we'll jump right into it. This is medication management of opioid use disorder. That's me. I have nothing to disclose. I have no pharmaceutical ties. This is a very similar lecture to the one we did back in February with a few additions to it. I work mainly in ambulatory addiction work now at WVU. And I also work for the, well, I don't work for it, I volunteer, but the West Virginia Society of Addiction Medicine, the chapter president. So anyways, the objectives, we're going to take a look at the medication options we have for OUD. We'll talk about the management and dosing of these medicines. We'll talk about the efficacy, comparing them, acceptance of the medicines, because it's one thing to actually have medicines. It's a whole nother thing for places to actually administer them or offer them. And then we'll also, as per tradition, add something sort of fun. So some incredibly cheesy puns, dad jokes to liven things up. So what I'm looking for is like Snickers or a little bit of a chuckle, but you don't really have to laugh out loud to make me feel better, but hopefully some interesting, fun ones. So this is my resource. So this is from Twitter. It's the punny world. So Twitter is just terrible, but there's occasionally some nuggets of fun that's in there, and this is what I have. So we'll start things off with a pun and go from there. So which program does a Jedi use to open PDF files? Well, of course, it's Adobe One Kenobi. So there you go. It's a nice dad joke / pun. So chuckles would be appreciated. MAT, or medications for opioid use disorder, MOUD, whatever we want to call it these days. Of course, it's a gold standard. It's the only efficacious and ethical treatment that we have available. Everybody recommends using them. We all know this. There's 3 medicines that we use. One is methadone. Lest we forget, it still helps a tremendous amount of people. We need more access to it. Naltrexone and then buprenorphine. And keeping in mind, as always, the goals of treatment are: 1 is to decrease morbidity and mortality. So less people suffering, less people dying. And then if they're going to be alive, let's increase their quality of life. And you can accomplish both through the use of medicines. All right, so some milestones in MOUD treatment. So methadone has been around for a long time. It was initially approved for detox, and then it became approved for maintenance. And 1974 was what created OTPs, which really has not changed in the last almost 50 years at this point. So really not a whole lot has changed with methadone, although there's talk of making it more readily available, because God knows we could use some more treatment options. It wasn't until the 80s that we got naltrexone in the oral formulation. We had the Data Act, which of course made it legal for us to prescribe things like buprenorphine, which are not approved until 2 years later. We got Vivitrol in 2010, and then the act in 2016, the CARE Act, which allows our nurse practitioner and physician assistant colleagues to be able to prescribe these things. And then I added in 2017 is when, in the US at least, we got our first extended release subcutaneous buprenorphine, which is Sublocade. So in general, they're very different, but they all help in their own unique way. So methanone's a full agonist, bupe's a partial agonist, naltrexone's an antagonist. They all have their pros and they all have their cons. Methadone's been around for a long time. We have a lot of experience with it. It certainly helps with pain. It is known to lower overdoses more efficaciously than any of the other ones. With bupe, we're reducing the risk of IV use. If we're talking about the subcutaneous formulations, now we don't have any risk of IV use, so that's good. It helps with pain. It's pretty easy. What do we like about naltrexone? Well, naltrexone is not diverted. There's no street value for naltrexone. There's no risk of overdose from it itself. You don't get dependent on it. There's not as much stigma. There's never no amount of stigma, double negative, but there's always some stigma, but there's less with naltrexone. The problems with methadone, especially in this state, extremely inconvenient to get. Only 8 or 9 methadone clinics in the entire state, which is ridiculous and something we're looking to change, hopefully. Not a whole lot of methadone gets diverted, but theoretically it can be. Lethal and overdose, absolutely. Too much methadone can kill you. Cons of bup, not a lot of doctors who prescribe. There is possible diversion. It does happen. Pretending it doesn't isn't effective. I think just being honest about these things is always the best policy. With naltrexone, the biggest issue with naltrexone, honestly, is compliance. People will get one shot, kind of assume that they're cured of opioid addiction, and then, a month later, the antagonist that is out of their system, and they're just as vulnerable, in fact, more so vulnerable to an overdose after the fact. It does not lower overdoses from at least a epidemiological standpoint. There is no decrease in overdoses with the use of naltrexone. So always keep that in mind. They're not equivalent to one another. So it would be kind of like methadone and bup are 1A and 1B. Naltrexone would be like 2C, kind of if you look at it in terms of what's best. So what happens if you do revive somebody of an overdose and then treat them with MAT? Well, this is a big study from several years back. Only about 3 out of 10 people, and we're talking thousands of non-fatal overdoses, received any kind of MAT. So 11% received methadone for 5 months, buprenorphine, 3,000 people received for 4 months, and about 1,000 received naltrexone for 1 month, again, because that's the most common number of times that people get naltrexone. So all-cause mortality was pretty high for people you can imagine that survived opioid overdoses, because if they've overdosed once, they're more likely to overdose again. But what you see was if you actually treated someone with bup or methadone, there was this great mortality reduction. So less people were dying. So people that had nearly died of an overdose, you plug them into treatment, they're much less likely to suffer from all-cause mortality after the fact if they're just on medicine. Again, methadone has the most evidence, buprenorphine less so, really nothing from naltrexone. So again, when we're comparing these to each other. So this is what I see as kind of a disturbing trend. I brought this up before, but with treatment. So every year there's this survey that goes out to every treatment facility in the US. And this can be outpatient, residential, or even hospital inpatient. And unfortunately, what they find is there's actually a lot of facilities, at least a few years ago, a lot of facilities in the US, including 116 in West Virginia. I don't know where they all are, but apparently there are 116 places throughout the state. Unfortunately, many offer no pharmacotherapies at all. So over a third of all these facilities across the US offer nothing, nada, zip, zilch, nothing. A large percent, almost 50%, offer no naloxone or overdose education, which is just sort of unbelievable right there that you don't even offer Narcan. Only about 35% offer Vivitrol, naltrexone, so that's not a huge amount. And very few actually offer Sublocade, which is more understandable because this is a newer medicine. And quite honestly, WVU in 2019, we didn't even have access to it. You see, there's really no excuse for no pharmacotherapies. Some of the other ones are a little bit more understandable, but it's a disturbing trend when you really think about it. So on to funny puns again. What does a thesaurus eat for breakfast? I like this, a synonym rule, of course. All right, so methadone. So what is methadone? Again, it's a full mu receptor agonist. You can only get it through an OTP. They're the only ones legally allowed to prescribe this stuff, although a doctor can prescribe for pain management alone. It gets a little gray when it's addiction plus pain management. I wouldn't want to go there legally speaking, but if you're prescribing for addiction, it has to be through an OTP. CYP3A4 is the main hepatic enzyme involved in metabolizing both methadone and bup. We'll go into a little bit of this. I don't know if Mark Raffley is on, but so warm his heart to talk about CYP enzymes. So the way that you dose methadone typically, and this is either inpatient or through an OTP, is generally the first day you're only giving people about 20 to 30 milligrams, and then you slowly increase it. Typically, 10 milligrams per week per time. I'm not an expert in methadone because honestly, we're not allowed to prescribe it at WVU. Other people like Dr. Hirschler spent a good deal of his career prescribing methadone to folks. But methadone is a tricky one to use. Keep in mind, again, it is a full agonist. It can cause respiratory depression, suppression at higher doses. We're looking at this, again, a full agonist, not something like a partial agonist or an antagonist. It does affect the heart as well. So that's typically what is monitored when someone's on higher doses of methadone is QT prolongation. So how do we do it? Methadone maintenance dosing. So the goal really is to titrate people to a dose that prevents opioid withdrawal, reduces what they call the opioid hunger, which is good, cravings, and also blocks or attenuates the effects of other opioids. Of course, while you're doing this, you don't want someone to be overly sedated either. So the target range, so if you're running into people on methadone, the target range is typically between 80 and 120 milligrams daily. I've certainly seen people on higher amounts, especially folks that are on like CYP-inducing medicines that drives down the levels to begin with. So you will see higher doses, you will see lower doses, but generally speaking, 80 to 120 milligrams once daily is the typical dose of methadone that you see clinically. If you see methadone given for pain, it's typically prescribed 3 times a day, and it's often like 10 or maybe 20 milligrams tops 3 times a day. So actually the pain doses tend to be less so than the doses we use in opioid addiction treatment. So again, CYP3A4, this will affect the levels of methadone for sure. Second trimester pregnancy typically requires higher doses due to the higher metabolism in their bodies. So what you will see is someone very stable on a lower dose of methadone, and then towards halfway through their pregnancy, which of course it's recommended to stay on while you're pregnant if you're already on it doing well. But what you typically will see is a need for higher doses, or sometimes dividing up the dose to kind of combat this higher metabolism. So, and when someone wants to come off of methadone, there are different ways of doing it, but typically it's increments of less than 10% every basically 1 to 2 weeks. So very slowly taking someone off methadone. It's not something you want to abruptly stop unless someone's in a hospital and can be monitored very closely. All right, so a little bit in the cytochrome P450, 3A4, i.e. CYP3A4. So don't commit all this to memory. I've found lots of different tables on the internet. I like some of them. I didn't like some of the other ones, so I just created my own. So here you go. So the big ones, substrate medication. So these are what are actually broken down by CYP3A4. So the big ones that we're concerned with here are buprenorphine and methadone, highlighted. So, but other things too, Elavil, phenytoin, Zoloft, Celexa, Effexor, Abilify, Seroquel, Klonopin, and Ambien. Lots of things are actually metabolized by 3A4. I didn't put it on here, but codeine is actually activated by 3A4. So most of the time we're talking about metabolizing to kind of turn it into something that's not going to be biologically active at all. But sometimes you need an enzyme to actually make something work. We'll put it that way. But in terms of what inducers are, so inducers basically make more CYP3A4 floating around, so it breaks down the buprenorphine or it breaks down the methadone quicker. So things like Tegretol, which you'll see that used a decent amount, Trileptal, Dilantin, phenytoin. So that's the highest levels I've ever seen of somebody on methadone was someone who was on phenytoin for a seizure disorder, and they were on like 220 milligrams of methadone. But in reality, it was probably more like 120 when you factor in the CYP induction. Another one you see, it's not quite as potent, but Topamax, we've been using more and more of that. Modafinil, you'll see that occasionally in addiction. Some other things, some more diabetic medicines. These are actually HIV medications here. The other one you occasionally see this from time to time, St. John's wort, and actually garlic supplements. So that'll drive down the levels of buprenorphine and methadone. Ones that'll actually be CYP inhibitors and drive up levels, the big ones that think about are, we certainly have people with that have fungal infections that end up on things like fluconazole. So you'll see that. Prozac, certainly. One little trick sometimes, if someone's buprenorphine is running out late or early, and say they have say they have depression or anxiety, you may want to consider Prozac because it'll actually kind of build up the levels of buprenorphine, or at least keep it from being metabolized so quickly. So sometimes using like CYP inhibition to your favor is a little trick that you can use, but Prozac's a big one. Some of these other ones I put diltiazem because that's what I take. So I got to keep that in mind if I ever end up on methadone. The other ones, the big ones, grapefruit juice, and our friend here, cannabidiol. So CBD. So generally speaking, we don't think of THC or CBD as being very active, psychoactive. We sort of just say, well, CBD, no big deal. That's true in many ways because it doesn't really mess with people mentally, but what it can do is certainly affect the levels of other drugs. So keep that in mind if somebody's suddenly using CBD, that might affect their buprenorphine or the methadone. You do notice on here that actually naltrexone, Vivitrol is not on here because it actually is not metabolized through the liver at all. So that's kind of a nice thing. Anyways, I hope Mark is proud. So another pun, I got fired from a canned juice company. Apparently I couldn't concentrate. I like that one. All right, so buprenorphine, we'll try to concentrate here. So of course, it's a partial agonist of the mu receptor. It has high affinity to the receptor. Typically, of course, we use sublingual forms, but also buccal forms, transdermal, and now we have these subcutaneous depot. It's nice. The dosing varies, of course. I put on here 8 to 24. In the past, I'd put 8 to 16, but really, we are seeing kind of an increased need for higher doses in certain circumstances. Getting it paid for through insurance is another matter. But I've become a lot more open to slightly higher doses if need be. We've kind of historically had this artificial cap of 16 milligrams for good reason too. But we've talked about it on ECHO before. There are certainly circumstances where people probably need to be on higher than 16. So just keep in mind. So when we are giving it to people, you guys all know how to do it, but we generally don't go over 8 milligrams the first day. We can make people sick by giving them buprenorphine because it has such a high affinity, but again, it's not as active. The receptor doesn't kind of get you where you want it to go, as opposed to a full opioid agonist. The minimum dose you see available is 2 milligram films. The FDA recommended max is 24 milligrams, although in the EU, and what we're studying is having people on upwards of 32 milligrams. I quite frankly was shocked that somebody who was say like 5 foot, 100 pounds, soaking wet could tolerate 32 milligrams. But having done it now for almost 2 years, the higher doses, depending on the person, people can do very well on the higher doses. And I don't think it's beyond the scope of reason to have some people on higher doses. So clinically right now, we're still living more in the 16 milligram realm, but my guess is we'll start using more 24 milligrams in the day of fentanyl. And potentially I could see the FDA cap raised to 32 in the future as well. So just kind of keep that in the back of your head. Okay, so the formulations of buprenorphine. So we have different ones, but typically we give it with naloxone, of course. So the big ones are Suboxone, Zubsolv. You'll occasionally see Unavil used. It's a buccal, not a sublingual. The mono product, people will say 54 411s. That's the kind of generic Subutex tabs. Sublocade is listed here. I also have Probufene. However, Probufene was taken off the market about 2 years ago now. So we never gave anyone an injection of it before, but it's not available in the US at this point. So no more. And it's the rods that you surgically implant in people's skin. So we're not doing those at the moment. So similar slide to the other one with methadone. This is from PCSS. So again, methadone or morphine, a full agonist is up here. Giving someone buprenorphine while it's still in their system will drive it down. So it'll block other opioids. It'll displace other opioids, which is not great if you're putting someone in withdrawal. Nice thing though is it stays on the opioid receptor for a while, so it's a slow dissociation. So those are good things and bad. All right. So what about Sublocade? So we tend to be using it more and more. This is an injectable subcutaneous buprenorphine solution. You got to refrigerate it. You can only leave it out for a few days before it goes bad. And it's very expensive. It's not something you want to leave laying around and let it go to waste. You've basically thrown away a couple $1,000. The indication is for people with moderate to severe opioid use disorder. And you must have someone take sublingual bupe for 7 days prior to starting Sublocade. So you can't grab someone off the street, put them on Sublocade immediately. At least you shouldn't, we'll put it that way. So you always want people to be stable on sublingual for about a week. In the hospital, we would often do that. And right before someone was leaving the hospital, then we'd give them Sublocade on their way out the door. There's only 2 doses that are available, 300 and 100 milligrams, and you can only put them in the abdomen. Really, you can stay on it indefinitely. The studies really weren't for that long, obviously. The studies, I think, were all for like 6 months-ish, but we're in COAT starting to have people now that have been on Sublocade for about a year at this point. Some people do really, really well with it. Keep in mind, it is being very, very heavily marketed by Indivior, which oddly enough, they also make Suboxone, the brand films. A big push has been to the legal system for planned prison release and drug courts ? So sort of for the reasons we stated, people don't like Suboxone, it can be diverted, blah, blah, blah. Sublocade, you really get rid of the diversion part. So I get why people would find the appeal with Sublocade. Okay, so how do you dose it? Again, there's only 2 doses. There's 300 milligram, which you're supposed to do for the first 2 months. And then the idea is to get people down to 100 milligram. You could have people stay up to 300 milligram if they don't do well on 100. And honestly, a lot of people that we've had in codes, we've tried to lower them to 100 and it just hasn't been the same. So many people have stayed on 300 milligrams. They say this is the comparable dose, sublingual dose. I question that honestly. Early on with Sublocade, we were worried that 300 milligram would be too much for someone who, say, was on 8 or 12 milligrams, but very few people have had problems tolerating that higher dose. And many people seem like they do better on the higher amounts of Sublocade for what it's worth. Okay, so these ones aren't available yet, but hopefully they will. Just a plug for them, because this is what we're using in research, but Brixadi, Buvidal, or CAM 2038. Very similar to Sublocade, but some key differences. So this has been approved and marketed in the EU since November 2018 as Buvidal. This was their version of Sublocade. Basically, the US, we had to choose between Sublocade and Buvidal, and we chose Sublocade, whereas the EU and Australia got Buvidal. We had it approved tentatively a couple years ago. It was supposed to be approved in December 2020, but then it got delayed. There were some issues with the manufacturer. And also there's this whole idea of exclusivity considerations. So basically, if 2 medicines come out at the same time, the FDA blocks one of the medicines. They sort of just choose which one to block because you can't have like 2 long-acting forms of Abilify or whatever it might be at the same time. So we don't have it yet, but we are hoping to get it anytime, really. I wouldn't be surprised if I read a thing from the FDA saying it was approved. Now, of course, once a medicine's approved, it takes 6 months or so to make it to market. My hope is that it'll give more options and also drive down the cost of Sublocade, because it's just outlandish right now. So what are the uses of a Brixadi? Very similar to Sublocade. So people that are struggling, you don't have to refrigerate it, which is really cool. And it has, this is key, monthly and weekly forms. So very different than Sublocade, which you're kind of locked in with 300 or 100. Lots of different doses. The idea being that you use these weekly doses to get people to the monthly, not keeping people on weekly doses indefinitely. So you put it subcutaneously. You can put it in the abdomen just like Sublocade, but you can actually put it in other areas of the body too, which kind of rotates spots. One of the common complaints with Sublocade is, you only have so many areas in the abdomen to give it, and people will start to have like lesions and things in their abdomen when they've had multiple shots. And of course, the final approval is pending, so we can't really do too much. So these are just some of the doses. Again, it's not ready for prime time yet, but you guys, whenever you see it become available, you'll have some idea what it is. And similar to Sublocade, some things in terms of injection site issues, constipation, just like any buprenorphine, nausea. Okay, so This is a little thing about buprenorphine versus placebo versus methadone. So this is a big Cochrane review. So bup is certainly effective for retaining people in treatment and suppressing illicit opioid use based on trials. So buprenorphine is less effective than methadone in keeping people in treatment if prescribed in a flexible dose or at a fixed and low dose. So low doses of bup don't tend to work nearly as well as methadone. However, if you give buprenorphine at fixed doses, which we typically do above 7 milligrams per day, so 8 milligrams or more, this is just as effective at keeping people in treatment as methadone. So just keep that in mind. These really tiny doses of buprenorphine aren't nearly as effective as the standard doses that we use, 8 to 12 to maybe, 8 to 16, maybe to 24. All right, so I like this one. I once was kidnapped by a group of mimes. They did unspeakable things to me. I think that's a good one. All right, lastly on the naltrexone, our old friend naltrexone. It's a full mu opioid receptor antagonist, similar to naloxone or Narcan. Minimal drug-drug interactions, but take care in a compromised liver. So if someone's liver is already bad, it's not great for them, although it doesn't have a lot of drug-drug interactions, if that makes sense. Naltrexone has a nasty way of driving up liver function. There's 2 formulations available. Revia is the tablet form. You don't really see brand Revia anymore. And then long-acting injectable Vivitrol, which is always recommended for OUD. There's only one formulation of the tablet, or at least dose strength, I should say, 50 milligrams. So it becomes rather inflexible if you're trying to use smaller doses, although pharmacies can compound less, and you'll see tiny doses used in research. There's only one dose of the injectable, which is 380 milligrams IM every 28 days. There is some efficacy in combining injectable naltrexone every 3 weeks with daily extended release bupropion. This is for methamphetamine use disorder. So this was an article that came out about a year and a half ago, but it was Vivitrol every 3 weeks plus Wellbutrin XL 450 daily. It drove down methamphetamine relapse a little bit. So that's, it's one thing to consider if you have somebody that really doesn't want to be on Suboxone and they're willing to take Vivitrol, Vivitrol plus Wellbutrin, it may actually help with meth cravings as well. Many of our people have that problem too. So some considerations with naltrexone. If you are going to do it, it is recommended to keep people opioid free for 7 to 10 days, because again, you don't want to put them in precipitated withdrawal. The better, the longer, the better, really, as long as they're in treatment. It is a challenge to keep people sober for that long, or at least I should say to get them through the really vicious opioid withdrawals. So getting them to the point that they can get on Vivitrol is often a challenge, but it's a doable challenge. We typically use non-opioid medications to suppress the sympathetic response of withdrawal. So the big ones are alpha-2 adrenergic receptor agonists, so clonidine, and then lest we forget, there's one called lofexidine or lucemira. I've never actually prescribed it because it costs about 1,000 times what clonidine does, so it's sort of pointless, but actually lofexidine is FDA approved to treat opioid withdrawal. It's the only medicine approved that way. It's kind of interesting. Doing it inpatient is typically the ideal, again, because initiating someone on naltrexone can be so tricky and you don't want to put them in terrible withdrawals. Okay. There are more rapid methods for naltrexone initiation that are being developed, but again, not ready for prime time. Things like Narcan challenge before you give somebody Vivitrol, for example. Those are just some things that you may see. All right, what I usually do is give someone naltrexone, oral naltrexone before I give them Vivitrol a shot. All right, won't go into it too much, but again, naltrexone, full antagonist, can certainly put you in withdrawals if you have either a full agonist like methadone or a partial agonist like buprenorphine on board. If you watch an Apple store getting robbed, are you an eyewitness? I think you are. All right, lastly, almost done. So if there's a facility, again, going back to the survey, facilities that offer buprenorphine with naloxone. So about a third did. Almost 2/3 do not offer any kind of Suboxone, basically. Buprenorphine without naloxone, so Subutex. 27%, no, 73%. So again, an incredibly large number of facilities that are treating addiction offer no kind of medicines whatsoever. So I question, should we call them opioid treatment programs if effective MOD treatments are not offered or they're prohibited flat out? So I would say no. All right, so in conclusion, it's the gold standard of medical care. It remains the only medically ethical and most efficacious treatment for OUD. So there are 3 medications that we have. They all have their pros and cons. Medicine management dosing, it still does remain dependent on the patient and the provider. Though keep in mind certain medicines, it's rather inflexible. Like there's only 1 dose of Vivitrol and there's only 2 doses of Sublocade. Many programs do not follow the standard of care, but we can do better, and we should really advocate for doing better. And lastly, happy holidays to all. It's hard to believe we're almost in December. If you have any questions, and then the last pun: as I get older, I remember all the people I lost along the way. Maybe a career as a tour guide was not the right choice. I like that. So does anyone have any questions whatsoever? I think I got through it just in time. 5 o'clock, not bad.
Perfect timing, Dr. Husted, and we can absolutely allot some time for any questions, comments, but I just have to give you a shout out. Love all the puns. I'm a big fan of dad jokes and
Nice.
absolutely a big fan of these photos as well. So thank you, thank you.
This was us on a cruise, little guys flashing. I think that's the peace sign. I hope it is, or it's a victory sign. I'm not sure the way he does it. So.
I love it.
Excuse me.
I just want to throw out something to think about with opiate use disorder treatment. When I worked with the methadone program, I did a study on employment rates in patients on methadone and looked at, what percentage of patients do a job where they're putting money away for Social Security versus working under the table or even committing crimes to support themselves. And so I'm interested in functioning on these medicines. Because people on methadone at such high doses, they kind of get into a nod and they just don't function well. And so I'd be interested at different doses, if you're going to use 32 milligrams of Suboxone, do people function differently?
I don't think so.
And not just Suboxone, but, look at naltrexone versus methadone versus Suboxone.
Yeah.
I think we should take a look at that and see if there's some impact on functioning.
I mean, with Suboxone, you have that ceiling effect basically. So it's like when I look at Suboxone at the higher doses, I'm thinking of it not like, it's 16 milligrams, say the dial is at 9.5, going to 24 is more like dialing up to 9.8, and maybe 32 is like 9.9. But it's not this thing like methadone. If you went from 100 milligrams of methadone up to 200 milligrams of methadone, clearly there's going to be a big change, but you don't really see that so much with Suboxone. I think just in general, fentanyl sort of changed the game in terms of how people, how their opioid receptors are, what doses they respond to. So
it interests me how the outcome measures tend to be retention or overdose.
Yeah.
They don't tend to look at positive outcomes like functioning, which patients really care about the most. Of course, they care about overdoses and staying in treatment and that sort of thing. But what really affects quality of life is functioning, right?
Absolutely, yeah, and I think often we do focus more on the not dying part as opposed to the living part. So it's interesting to think about that for sure.
If we have time, I have a couple of quick questions. That was a great presentation. Thank you so much, including the puns.
You like them?
You didn't in the first part. Yeah, I do. In the first part, you didn't mention the potential for intoxication. And, I've heard patients say that they like methadone because they can get high. And so could you talk a little bit about that?
Yeah, I mean, quite frankly, in this day and age, you can get high on just about anything. So I always kind of take it with a grain of salt because people, if you're on Suboxone, there's nothing stopping you from using methamphetamines, for example. Methadone definitely is can be more of a companion with full opioids for sure, as opposed to Bube, which is going to largely be kind of a waste of money for folks. But the reality is a lot of people that are on methadone, you don't see a whole lot of overdoses, like, thousands, 100,000 people that die a year, or whatever it is recently from opioids. Typically it's like 1 or 2,000 per year dying that have methadone in the system. So people that are in methadone clinics, they may occasionally use other things, but they're not using to the point of overdose being very common. So there's something to be said for that, I would say.
Yeah. I also wondered if anybody could speak to, after I think it was your previous presentation on Sublocade, I asked our pharmacy about it, and they said they had to go through some special licensing procedure to be able to dispense it. And is that true?
Absolutely, unfortunately. So there's the REMS program. It's similar to clozapine or Zyprexa, was it Relprev, if anybody's familiar with it. But the whole idea is basically the DEA makes sure that the patient never has any access to the medicine whatsoever. So if you write Sublocade, it has to go directly from a pharmacy that's under this REMS waiver to the administering clinic. So you can't just order Sublocade to anywhere. There's actually even further rules where it's supposed to not be a pharmacy that has a like a retail part to it. It has to be like a hospital almost pharmacy. So it is very tricky. I mean, it took us like 6 months to get the REMS program in place, and then even longer for everything. But if you can do it now, I mean, it is a preferred medicine on Medicaid. I will say, though, that there's concern that there are some doctors that have really pushed Sublocade on everybody when they probably shouldn't. And I think there's one doctor that's writing like half the Sublocade in the whole state right now. And so it's kind of one of those things, if we overdo it, then we might lose it for everybody. And honestly, not everybody is appropriate for Sublocade. So it's a good medicine for some. It's not a replacement for Suboxone, I'll put it that way. It's sort of just another tool to have. I think Brixadi will be better once it's available, having used it in research for what it's worth.
Can I sneak in one more quick question, Mitra?
Sure.
I just started prescribing people Topamax who are stable on their Suboxone as far as heroin or fentanyl goes, but they're still using meth, regular basis. And so that was really interesting about it being an inducer. How often does that put people into withdrawal? Or
I don't know if we put. It's not as strong of an inducer as some of the more like traditional anti-epileptics, but it's just something to be mindful of. If you start someone on Topamax and then suddenly, they're talking about opioid cravings, that it might have been something that we did iatrogenically. So the reality is so many people are on like CYP inhibitors and inducers at the same time. It's like it take Prozac and it take Topamax. What does that equal out to? And I eat grapefruit juice every day. It gets tricky. I imagine if Mark were here, he'd be like scratching his head right now or something. So it's certainly something to just keep an eye on. So if someone says that they don't feel as well once they're on Topamax, there might be a good biologic reason to. So.
Any other questions, comments from the group? Thank you, Jen, for all your questions. We do appreciate that.
Thanks, you guys, for hanging in there, because I just had a lot to ask about.
No worries.
Very, very helpful.
Jen, next time you need to get a Buffalo Plaid shirt.
That's the requirement.
Everybody's doing it. So. Dr. Hirschler has on some plaid, so I respect that. Very good.
Yeah, he's matching me, black and white. Alrighty, well, if there are no further questions, thank you all so much. Thank you, Dr. Husted, as well, for the presentation in that short allotted of time. So thank you. The announcement I have is that the next session will be on December 12th. Katie Shazlan-Downs will be presenting on compassion fatigue. All right, thank you all so much and have a wonderful evening.
Take care,
everyone.